Good morning, ladies and gentlemen, colleagues and friends. First, I want to apologize for the fact that I cannot be with you today in person, but I want to thank the organizers for giving me the opportunity to appear with you by video. Let's take a look now at the title, the HIV pandemic. I'm going to talk about some historical perspectives and the role of the Rakai Health Sciences Program. I'm going to do this by dividing it into two separate buckets. First, a historical perspective, taking a look at where we've been, where we are right now in the HIV/AIDS pandemic. As you well know, it all goes back to the early summer of 1981, when the first cases of what would soon be known as AIDS were reported in 5 young, curiously all gay men from Los Angeles who presented with pneumocystis pneumonia. 1 month later, in July of '81, 23, again, young, otherwise previously well, gay men presented not only in Los Angeles, but in San Francisco and New York City, not only with pneumocystis pneumonia, but also with capsarcoma and other opportunistic infections. At the time, my career was devoted to the interface between the immune system and infections, and I was having a rather successful, happy career. But I made a decision in June of 1981, when I first heard of those patients, that I would change the direction of my career and study exclusively what was then considered a disease among gay men. My mentors discouraged me from doing this, saying that I was throwing away a promising career by doing this. So I thought I needed to write something to essentially explain why I was doing this. I wrote it in December of 1981. It was rejected by the first journal I sent it to because they thought I was being alarmist. So I sent it to the Annals of Internal Medicine, who finally published it in June of '82. And as you see with the quote on the right-hand side, because we do not know the cause of this syndrome, any assumption that it will remain restricted to a particular segment of our society is truly an assumption without scientific basis. And unfortunately, this was indeed prescient, because as the months and the years went by, we began seeing it again progressively in different demographic groups. Haitians, people with hemophilia, people who receive transfusions, infants born of mothers who were afflicted with this disease, and the sexual partners of males with known acquired immunodeficiency syndrome. This is a picture of me in the early 1980s. In fact, this picture was taken in December of 1981 in one of the first AIDS patients that we admitted to my ward at the NIH. Since we did not have any diagnostics and we didn't know what the name was of the disease, it was not named AIDS yet, it certainly didn't have an etiology, and for sure there were no specific treatments. The median survival was drastic, sometimes about anywhere from 6-8 months to a year, because patients presented so late in the course of disease. We soon realized that HIV/AIDS was not something peculiar to the United States, but it was a global pandemic. And a lot of that information came from our colleagues in Africa, who began seeing something quite similar, however, mostly in a heterosexual population, which puzzled people who were somewhat slanted in their thinking that this was a disease only of gay men. But it soon became clear that Africa was more severely afflicted than was the United States. In fact, if you look at this map from the year 2000, there were 36 million people living with HIV. In fact, very similar to the number now, because many more have gotten infected, but many have died. But the important part about this map with the numbers is that about 90% of the infections were occurring in the developing world, and about 2/3, or 67%, were seen in Southern Africa. With the investment in biomedical research, the advances in HIV/AIDS science from the time we first recognized the syndrome in 1981 to the present time have been nothing short of breathtaking. Of particular importance have been the advances of treatment, which emanated from an understanding of the HIV replication cycle and all the important vulnerable points for which one could either screen for or design antiviral drugs based on the replication cycle vulnerable points. The first success came with AZT, which was actually a drug that was screened and already developed. And in this now classic paper in the New England Journal, showing that in the placebo group there were 19 deaths, in the AZT group there was only 1 death. But importantly, this victory was transient, because with a single drug and the virus mutating, the effect soon diminished rather rapidly. However, the progress over the years was clear. As shown on the left-hand panel, with AZT monotherapy, the level of virus dropped modestly, but did so for a very brief period of time. As we got to 1984 with 2-drug therapy, particularly with lamivudine added to AZT and other drugs, it was a much more dramatic drop in viral load, but again, it was not durable. It was only until 1996, with the triple combinations of drugs that were ushered in with the use of the protease inhibitors, did you see a drop of virus to below detectable level that was durable. This, in fact, led to more than 30 drugs right now, which when used in combination have totally transformed the lives of HIV-infected individuals. Some of these combination drugs, as shown on the right-hand side of the slide, can be given as a single tablet once a day. This completely transformed the lives of HIV-infected individuals, as shown dramatically on this slide. Comparing to what I showed you back in the 1980s, if a 20-year-old came into my clinic or any clinic that was taking care of HIV-infected individuals, and that individual was newly diagnosed with HIV, and I put them on a triple combination of drugs, I could project very accurately that that person would live at least an additional 50 years, giving them essentially, not quite, but essentially a normal lifespan. Because of this dramatic success, it became clear that treatment access was a profound issue, because individuals in the developing world did not have the access that we in the developed world have. And this really was personified by the kinds of demonstrations that we saw in Durban, South Africa at the International AIDS Society meeting in July of the year 2000. Which brings me to the second component of my talk, the role of the Rakai Health Sciences Program, which I divide into 2 major components, namely its role in kindling in me the ideas of the possibility of a PEPFAR-like program. What do I mean by that? It was clear that this disease, which was sometimes known as slim disease in Africa in this paper from Uganda, as well as the spread in the rural district, in this case Rakai of Uganda, was a complete awareness now of the profound nature of this threat in Africa. And the real question was, can you deliver the kind of care, treatment, and prevention in that environment that was being delivered in the developing world, saving so many lives? For me, this all changed with a trip that I took to Uganda in April of 2001. Listed on the slide are the names of just some of the individuals, and the reason I list them is that I made notes during that trip of people that I had conversations with, that I got to know, and I got a feeling for what can and cannot be done in Southern Africa. These are some of the individuals who had an influence on me in my discussions during that relatively brief visit to Uganda. One of the individuals who had the most profound effect was a person that I got to know well during that short period of time, Noah Kiwanuka. And I saw in Noah the passion and the drive and the commitment to bring, in this case to the Rakai district, the kind of treatment, care, and prevention that was available in areas of the world with much greater resources. In fact, what I saw in a remote hospital in Calazizo, I saw the kind of care that was possible under the most difficult conditions. Because of that, I began thinking that perhaps we could do this in Africa in a manner similar to what was being done in the United States. Along came President George W. Bush, who deserves such an extraordinary amount of credit for what turns out to be one of the most extraordinary programs of global health in history. The president told me personally in a meeting to which he invited me at the White House, we as a rich nation have a moral obligation to help those who do not have access to HIV treatment and care because they lack the resources. And with that, he sent on a presidential trip to Africa, Tommy Thompson and I, to determine the feasibility of being able to put together a transformational program to give care, treatment, and prevention to people mostly in the developing world in Southern Africa. I made a trip in April of 2002 to these countries with Tommy Thompson, and I found on the ground, as this young woman who had enough resources to buy drugs for a limited number of people. Here is her on a motorcycle. I'm following her in a Land Rover, taking us to a remote village where we distributed the drugs to people who understood the disease, who were willing to take their medication, and in whom the medications were working. I became convinced as I went through other regions of Africa, other towns, other cities, that this could be done in Africa if they only had the resources. I went back and over a period of many months, from April, May 2002 to the end of 2002, putting together with Mark Dybel and others from the White House staff, putting together the architecture for what would become the President's Emergency Plan for AIDS Relief. To his great credit, this whole process was driven by the will of President George W. Bush. And on January 28, 2003, he announced the President's Emergency Plan for AIDS Relief, which early on was a commitment of $15 billion over 5 years to prevent 7 million infections, to treat 2 million people, and to care for 10 million HIV-infected people, including AIDS orphans. Fast forward 15 years later, the impact of PEPFAR has been profound, with 14.6 million people having received ART, 2.4 million perinatal infections averted, almost 19 million voluntary medical male circumcisions, and 95 million people receiving HIV testing and care for over 6.8 million orphans. It was with great gratification that we assembled in Dallas 15 years later at the invitation of President Bush. And this is a picture of me with Paul Farmer and Barbara Bush on the left, President Bush's daughter, and Senator Lindsey Graham, to talk about and discuss what had gone on over the previous 15 years. So I think one can say without any exaggeration that my initial visit to the Rakai Health Sciences Program had a profound impact on my realization and my activities afterwards about what could possibly be done with a PEPFAR-like program. I want to just spend the next couple of minutes talking about my appreciation and the appreciation of so many other people of the role of the Rakai Health Sciences Program in the global effort against HIV/AIDS. And again, I'll divide that into three among several major accomplishments of the Rakai program. First is the issue of viral load and HIV transmission. It was in the initial paper shown here in the New England Journal of Medicine in 2000 when the study of serodifferent couples found that viral load is the primary determinant of HIV transmission. Seems simple now, but it was that paper in which we first realized this. This led to the now iconic study of HPTN 052, which showed that if you take individuals who are serodifferent, one infected, one not, and you treat early the infected individual, you decrease by more than 95% the likelihood that that person will transmit the virus to their uninfected partner. This concept was completely proven without a doubt in 3 separate studies, predominantly in gay men. The partner study, Opposites Attract, and Partners 2, that showed there was no linked HIV transmission associated with more than 150,000 acts of condomless sex when the partner was stably suppressed by ART, leading to the now unequivocal concept that undetectable does equal untransmittable. Next came voluntary male circumcision. Again, one of 3 studies shown here from Rakai, clearly showing that adult male circumcision significantly reduced the risk of acquiring HIV in a man. In fact, Time magazine thought so much of this that it made in 2007 this as the number 2 among the top 10 medical breakthroughs of that year. Not only was the effect profound, but it was durable, as shown here in a post-trial follow-up of more than 40 months of the diminution of the probability of HIV infected in circumcised man. And then finally, the implementation of combination HIV prevention. In this paper in the New England Journal of Medicine, showing that in Uganda, a longitudinal study of incidents with scale-up of combination preventions led to a 42% reduction in HIV incidence. In a news release by NIAID, we touted this study as being absolutely important in proving what we've been trying to determine all along, that combination prevention can have a major impact on reducing the incidence of HIV infection. And so I want to close by giving my sincerest and heartfelt congratulations and thank you to you all in the Rakai program for more than 30 years of service. And again, I want to take this opportunity to thank you for giving me the possibility and the capability by this video of joining you in what is, in my mind, a well-deserved celebration. Have a wonderful meeting, and thank you very much.